My name is Alberto Sobrero. I'm the head of the medical oncology unit here in Genoa, and I have the privilege to welcome you all to this GI Cancer Masterclass. Well, before the pandemics, the GI Masterclass was a very nice meeting sponsored by Servier that I thank fully because of the opportunity of having these exchanges. And their meeting in the previous years usually lasted about 2-3 days and covered a lot of topics. And now in the pandemics year, we have decided to split this meeting into several segments, and this is just one of them. And more will come up in the hope that very soon we'll meet in person. Well, this meeting is very special because it deals with guidelines in metastatic colorectal cancer. Now, if I can have the next slide, please. Okay, the issue is very intriguing and fascinating. And we will go into the details of what's behind the guidelines. What are the evidence that we need in order to write the guidelines? But we will go further beyond the guidelines because in order to take our decision in clinical practice, we need also something else. And the purpose of this webinar is illustrating the guidelines, what is behind the guidelines, there's something else that is needed in order to take our decisions in clinical oncology. And we will do a very nice exercise in trying to see how the present guidelines can and should be modified. So I have the privilege to welcome the rest of the faculty here, and you can see the program there. Professor Per Pfeiffer from Odense in Denmark will cover the topic from clinical trials to patient benefits, how guidelines serve physicians. Then I will cover the topic of what guidelines do not and cannot tell us. So I will cover the topic of what else do we need beyond guidelines in order to take our decisions. And Chiara Cremolini from Pisa has the challenge to illustrate how she would change the current version of the ESMO guidelines in 2021. I'm longing for hearing this, a new version of the guidelines. Then we will take questions, and then the meeting will end in about an hour and 15 minutes. So without further ado, I call Professor Per Pfeiffer to cover the topic of from clinical trials to patient benefits, how guidelines serve clinicians. Per.
Thank you, Alberto. Yeah, thank you to Servier for inviting me. I'm really honored to be here with Alberto and Chiara, and I hope that you will enjoy the next hour. I'm going to talk about clinical trials to patient benefits in metastatic colorectal cancer. These are my disclosures. So if I start back in 2000, at that time there was a lot of trials who showed that the doublet was more effective than monotherapy, and we learned that we could start with oxaliplatin combination, and that could be followed by irinotecan, or it could be the other way around. We also learned that we could use targeted therapy that would improve efficacy. It could be either anti-VEGF antibody or anti-EGFR receptor antibody. And since then, for many years, we have been discussing which one we should use. We also learned from Dr. Falcones and Dr. Cremolini's group that the triplet is more effective than the doublet. And we met to discuss these things back in 2014. There were different groups. I was in a group where we should discuss first-line treatment, and I was with Alberto Sobrero, who actually was head of that group, and this was the final version, the paper version of the new ESMO guidelines, and we made more readable version of the ESMO guidelines, and the ESMO guidelines ended up with this. And I think that at that time we made it clear that first we should discuss whether the patient is fit or unfit for treatment, and if we have, and when we have evaluated that, then we should find out what is the goal of treatment. Is the goal cytoreduction? That could be for surgery, or it could be because the patient had a lot of symptoms. In these cases, it is very important to have cytoreduction, and then we should of course use the most effective treatment. If the patient was RAS wild type, we should resume anti-EGFR receptor treatment, and if the patient was mutated, we could use bevacizumab. There was an updated version. It was the Pan-Asian Adapted ESMO Consensus Guidelines, and when we did the ESMO guidelines, we had also some Japanese friends in the group. They made the difference between the 2018 guidelines is that they have looked into whether the primary is left-sided or whether it's right-sided. So if it's left-sided, we should use an anti-EGFR antibody. This is another way of looking into precision medicine. We should, of course, evaluate the patient, the disease, the tumor. What is the resectability? Is there any chance to resect the tumor? What is the tumor burden? Do the patient have symptoms? What is the location, left-sided or right-sided? We know there's a big difference in tumor biology between left and right-sided, and all patients with metastatic disease, they should have an evaluation of molecular factors like RAS, BRAF, mismatch repair, HER2. We should, of course, also look into the patient, the performance status, age, organ function, but also very important nowadays, what is the patient's preference? What do the patient want? And this choice of the first-line treatment has influence on the next steps within this continuum of care. And this is my preferred choices in first-line treatment. If the goal is cytoreduction, then we should use in patients with RAS, BRAF wild type and left-sided, they should be treated with doublet plus EGF receptor inhibition. In patients with RAS mutation, it could be triplet with or without bevacizumab, or doublet with or without bevacizumab. In the few patients, 5% perhaps, with a deficient mismatch repair, then pembrolizumab was recently approved, so this will become the treatment of choice in first line. In patients with BRAF mutation, there's no established treatment yet. If the goal is disease control, then we can, of course, we can use the same treatment, but in many cases, start with capecitabine and bevacizumab is a very tolerable treatment for most patients, and the same could be used in patients who are frail. This is how it could look in a patient who could have many lines of treatment, and all these small incremental steps and sequential use, this will lead to improvement in overall survival. But we must also realize that some patients, they will never receive second or third or later line of treatment. What we know in patients with chemorefractory disease, we know that trifluidine tipiracil prolongs overall survival, and the same goes for regorafenib, but there are actually no other chemotherapy drugs that has shown benefit from randomized trials. So in third line and beyond, in unselected patients, it could be trifluidine tipiracil or it could be regorafenib. In patient who has not been treated with EGF receptor inhibition, then of course they should be treated with anti-EGFR if they are RAF and BRAF wild type. But it's also an option if the patient has been treated in prior lines, that there's an option to rechallenge the patient with anti-EGFR treatment. In the patient who are BRAF mutated, recently encorafenib and cetuximab was approved, but probably most physicians will use this in second line. There are phase 2 trials showing a benefit of HER2, anti-HER2 combinations like trastuzumab plus lapatinib or trastuzumab plus pertuzumab, but there are also other combinations, but none of these are approved yet. And in patients with deficient mismatch repair, there's no, in Europe, there's no approved drugs yet, but many will use some kind of immunotherapy. Just briefly, I will show the Danish trifluridine trial. We treated the patient with trifluridine, tipiracil, the standard regimen, with or without bevacizumab. We wanted to prolong progression-free survival from 2.5 to 4.5 months. A small trials with little less than 100 patients performed in 4 Danish sites. The primary endpoint was progression-free survival, and actually we succeeded to prolong PFS from 2.6 to 4.6 months with a hazard ratio of 0.45. The overall survival was also prolonged from 6.7 to 9.4 months with a hazard ratio of 0.55, significantly different. And of course, this will not be immediately included in guidelines, and I could doubt whether it would be possible to use it based on email recommendation, but I was very glad when I saw the NCCN guidelines for colon cancer. In the most recent version, they stated that after previous oxaliplatin and irinotecan, they recommend trifluridine, tipiracil, a third line, with or without bevacizumab, and this was actually based on our Danish trial. So I was very proud when I saw that. This is a force plot of subgroup analysis from the Danish trial, and for me the most important was that what about prior bevacizumab? Around 80% of the patients, they had received prior bevacizumab. About half the patients had received bevacizumab in the immediate past line of treatment before they were treated with the trifluridine. And as you can see here, there's no major difference. So it seemed as if patients who has been pre-treated with bevacizumab, they still benefit from the combination of trifluridine, tipiracil with bevacizumab. These are the most frequent toxicities. It's well known from many trials that around 1/3 of the patient, they will develop grade 3 or grade 4 neutropenia, and that is the most frequent severe toxicity from trifluridine, tipiracil. And when we are combining it with bevacizumab, actually 2/3 of the patients, they developed the grade 3 or grade 4 neutropenia. However, it was only 1 and 3 patients who actually developed febrile neutropenia. And inspired by the recourse trial, we did not evaluate quality of life, but we looked into a surrogate marker of quality of life, time to worsening of performance status to 2 or worse. And as you can see here, the time to worsening of performance status was significantly prolonged from 4.1 months to 8.7 months. So in conclusion, guidelines are built on clinical trial data, of course, but guidelines do not always reflect clinical practice. There are differences in guidelines dependent on geography, and not all treatments suitable for patients are actually included in guidelines. Thank you.
Thanks for this brilliant presentation, and especially and congratulations for getting your phase 2 randomized study into the NCCN guidelines. I'm not surprised about that because the internal consistency of the results of your trial is very high. You see a very nice prolongation in PFS, almost a doubling in PFS, and that has been confirmed with an extension in survival, and that's very nice. Because we are ahead of time, I take the privilege to ask you 2 questions on this specific study. The first is that I remember when bevacizumab was launched, we all were very convinced that beyond second line, bevacizumab would have no effect. And that was mainly based on an American study that is called the TRC 301 on 300 patients, showing no benefit. Now, the benefit that you show is very convincing despite a relatively small number of patients. Do you think that the peculiar way of mechanism of action of trifluridine, this agent may be potentiated specifically by bevacizumab, as has never been seen in the past, because of what you have found?
Thank you for these nice words, Alberto. Good question. I don't think it's especially about the trifluridine tipiracil. I also think that it will work in other situations. And personally, I have had a problem because I have not had an option in third or fourth line of treatment. So in many patients, I have used a combination of capecitabine, or I've also used the Japanese version as one. I have used those drugs in combination with bevacizumab, and of course, when we have evaluated efficacy, it also seems promising. So I don't think it's not only trifluridine tipiracil, but it will also improve efficacy in later line.
Okay, and the second question is that I was impressed to see the low-grade subjective toxicities in your study, specifically nausea and vomiting. You have reported 70% of nausea, grade 1-2, which is very small, and we tend to underreport that. In this case, of course, you overreport that. But it has a very strong implication, because my impression is that because trifluridine has this very nice connotation of being so well tolerated, oncologists tend not to give medication against nausea and vomiting. And that is causing some problem, because sometimes it's just a matter of giving some metoclopramide and then all those issues are over. What's your feeling about this practical aspect?
Oh, that's a very good point. We always give some antiemetics to the patient so they can take it as necessary during the treatment when we are giving the patient all treatment. So it's a very good point. But we must also remember that patient in third or fourth line, the disease by itself can also cause fatigue, nausea, and these things. But I agree, of course, the patient should have the option.
Yeah, I think it is an important point, a very practical kind of side of main track point that may help people. Okay, thanks very much, Per. Now it's my turn, and I have the privilege to cover a topic that to me is very fascinating, and that is what guidelines cannot tell us, and essentially deals with our problem of taking decision in medicine. Okay, what guidelines do not and cannot tell us? This is how I approached this problem. Guidelines are only a component of relevant scientific evidence, And relevant scientific evidence is only one component of evidence-based medicine. That is the only way to practice in the best way the current medicine. Taking decision in medicine is a very difficult process, and the best way is universally recognized to be through evidence-based medicine. So we'll go through what is evidence-based medicine. Now, the problem is that there are complicating factors in taking our decisions. And these complicating factors I summarized in two ways. Number one, the irrationality of human being, and number two, that sort of internal voice that is called by psychologists and psychiatrists the narrating self, that is the so-called narrating self that tends to give sense to all what happens to us, tend to leave out the disorderly part of what's happening to us and give a certain sense. On top of all these complications, we have the sustainability of our decision as an additionally complicating factor. So what is evidence-based medicine? I said that guidelines are only a component of evidence-based medicine. And here is what it is. You see here the ball of relevant scientific evidence. And that is accounted for by both clinical trials as well as the summary of clinical trials, meaning the guidelines. But evidence-based medicine is not only relevant scientific evidence. It is made up also by our clinical judgment as well as the patient values and preferences that we must take into account in order to make our decisions. So essentially, whenever we run a clinical trial, we do not answer the question, what should I do on my patients? We simply come to a conclusion to establish a general principle. Now, the summary of general principles that are coming from clinical trials constitute the basis for us, for experts, to say what guidelines are. However, this is the word of the scientific evidence, but still this is the word of taking decision. And between this word and this one, there are kilometers. There are differences that are qualitative in nature. They're not quantitative. So essentially, this difference accounts for the pursuing most efficacious treatment through clinical trials and guidelines that are dependent upon deltas and p-values, and pursuing the best choice among the one available in our practice, and best is a non-scientific term. So essentially, the two words define the word of science on one side and the word of the art of medicine on the other side. So that ball of relevant scientific evidence is not enough. There is something more. So that whenever we sit down and try to develop guidelines, we tend to scotomize, to minimize the patient-related factors that play such a great role in taking decisions. Whereas whenever we sit in front of our patient, as in this case, the patient dominates. Okay. So essentially, I have covered the fact that evidence-based medicine is made up by three different components. Relevant scientific evidence made up by trials and guidelines, my clinical judgment, and the patient preferences and values. It is the intersection of these three that allow us to practice medicine in the best way, and that is practicing the so-called shared decision-making. I don't know if you noted that at the last couple of ASCO, there were two mantras. Number one, precision medicine. Number two, shared decision-making, to emphasize this intersection between the best evidence, clinical evidence on one side, my clinical judgment, and the patient preferences and values. Nevertheless, be careful, because if you emphasize too much the relevant scientific evidence part of evidence-based medicine, you run into the problem of the so-called cookbook type of medicine. If you have a hypertrophic clinical judgment, you run the risk of pursuing a paternalistic type of medicine. Whereas if you are too inclined to follow the patient's suggestions, then you're practicing a so-called consumer type of medicine. So it's a balance among them. But this balance is very difficult, and it is further complicated. Point number 4 of my talk is further complicated by two things: the irrationality of the human being and the narrating self. What do we mean by irrationality? Well, there is a historical background to this. Through the last 4 centuries since the scientific revolution, 17th century, the human being has been seen by the different movements, the philosophical movements, has been seen in 2 different ways. More emphasis being placed on the rationality of human beings, such as during the Illuminism and the British rationalism, or positivism or realism, or on the opposite side, through the romanticism or idealism, the human being has been seen as an irrational being. What we know is that both things are correct. We know that our judgment and choices and decisions depend on logical analysis, meaning rationality, but also on emotions and unconscious information. And here things get tricky. Now, the neurobiologic basis for these 2 words in our decision-making process that influence our decision-making process has been developed and discovered during the last 20, 30 years. Essentially, it has been established that the human being processes the information in order to come up with decisions through 2 systems. One goes through the amygdala and the other goes through the cortex. The first is called System 1 and the second System 2. Be careful, because behind this information we can account 3 Nobel Prizes in the last 18 years. So I'm not telling you things that are collateral. This is relevant scientific evidence, okay, to stay on the theme. Okay, so System 1, that is the unconscious, is fast, automatic, and unfortunately prone to errors. This system tends to deceive us. System number 2, that goes through the cortex, is conscious, is rational, is slow, takes time. It requires effort and is used for complex decision, but is reliable in general. And we must be careful in not being overcome in our choices by System 1. So just a couple of examples. If I say 2 + 2, you don't need to think, you go with a 4. If you hear boom, you turn toward this sudden noise and there is nothing doing, you do it. Okay, if you see a large advertisement, you simply read it. You cannot stop it by reading it. And that's the the outcome of system 1 being enforced. If I say 17 by 24, well, you don't answer. You need a pencil, you need time, you need effort, parking in a narrow space, self-control of our behavior at the party. Okay, all these are functions that needs effort and go through the cortex. Now, unfortunately, I said that system 1 tend to deceive us, and this is a very good example of perceptive illusion. Now, everybody of you, if you look close to this and try to answer the question which segment is longer, understands that there is some trick behind it. But you need to concentrate and spend time to say that the two segments are the same. Because if I asked you in 1 second, tell me which of the two segments is longer, every one of you would tend to say it's the upper one. Okay. Let's make an example of system 1 and 2 in force in, say, trial interpretation of clinical trial. You see hazard ratio 0.45, and your system 1s tend to deceive you by saying, oh, it's fantastic. Then your cortex come in and tells you to ask yourself, are these data true? And then you go through the 4 domains of a classical answer in this question. That is internal validity, internal consistency, external consistency, and biologic and clinical plausibility. Okay, and only after you go through all this process, you can say that these data are true, and then therefore your reaction, fantastic, is true. And the same may happen with a hazard ratio of 0.8. Well, disappointing, well, depends, because sometimes, let's say, if you have a median survival of 4 years, a 20% increment may be almost a year gained. So your system 2 may correct your system 1. Okay. Now, how, through which processes our system 1 try to deceive us? Through the systems of biases and so-called heuristics. Heuristics are sort of cognitive shortcuts and tend to make us focus on the most relevant aspect of a complex problem. I think an example may explain this, because it took to me a lot of time to understand these concepts. But say, this is a very good example of heuristics of availability, okay? A patient saying, I saw my sister dying of cancer while getting chemo. I don't want to get chemo for my cancer now. This is a classical example of heuristics of availability. That is a shortcut. I don't consider anything else. I remember it went bad, so I don't want it, period. It's a simplification of a complex problem. And this is how it happens that our system 1 may deceive us. So system 1 is based on feelings, as you saw, believes whatever appearances are, and overestimates low probabilities. This is why we play lotteries, because human beings are subjected to the fascination of lotteries, of low probabilities. And these somehow, you see these minuses here and there, means that they impact on the doctor's clinical judgment, trying to deceive his judgment, but also on the patient values and preferences. However, there is also a positive aspect, and this is the scientific reason why the clinical judgment is part of evidence-based medicine, okay? And that is because the system 1, if adequately trained, may generate the so-called expert insights. That is, within seconds, you know whether to treat a patient or not. Within seconds, you know whether to go for an aggressive type of choice or a much lighter type of choice with our patient. And that has a very long story behind. Essentially has to deal with the fact that medicine is very repetitive, opposite to what the world of politics, economics is. Expert insights in economics and in politics is impossible, whereas it is possible in medicine. Okay. So now the second complicating factors is the so-called narrating self. And this is a very interesting factor. Patient and healthcare professionals and every human do not process information as computers. We build our own story, our own reality through our internal voice called narrating self, the interpretation of what is happening to me. And see that bolded sentence. We carve out order by leaving out the disorderly part. So we interpret things, we try to give to them a certain sense. Now, so I have explained to you that evidence-based medicine is composed by relevant scientific evidence, clinical trials and guidelines, the clinical judgment that has a scientific value because of my system 2, but also because of my system 1, okay? And the patient values and preferences. Now, on this and that ball, the system 1, system 2, and narrating self play a lot of important strength in our decision making. The only aspect that is free from human bias is relevant scientific evidence. Unfortunately, to complicate things further, we have the availability, affordability problem, so that in our taking decisions, we have also to consider the so-called value-based medicine. That is, okay, doing all the best that the relevant scientific evidence offers to us, but that has also to be sustainable. So I illustrated to you the 3 dominant aspects of evidence-based medicine. I told you about the other 2 complicating factors in taking decisions according to evidence-based medicine, and that is the system 1 and system 2, along with the narrating self. And I will conclude by the last sentence that is reported here, saying that evidence-based medicine overcomes the limit of relevant scientific evidence that would reduce medicine into just a cookbook type of medicine, thus allowing shared decision-making. I thank you all for listening, and now I have the privilege to pass the microphone to Dr. Chiara Cremolini with a very challenging title of How Would You Change the Current Version of ESMO Guidelines in 2021? Chiara.
Thank you, Alberto. Thank you so much. First of all, I'd like to thank the organizers to give me the opportunity to issue this topic, which is quite challenging, and to propose some changes to the current version of the ESMO guidelines. These are my disclosures. What am I referring to when speaking about the last version of the ESMO guidelines? The last version has already been cited by Professor Pfeiffer. It's the version published in the Annals of Oncology in 2016. Then 2 years later, there was a kind of update of these guidelines made in collaboration with the Pan-Asian Association of Medical Oncology. In 2016, this was the therapeutic algorithm that was proposed for the first line of treatment of metastatic colorectal cancer, and the three main drivers of our choice were evidenced. First of all, the careful evaluation of patient general conditions, ECOG performance status, comorbidities, expectations and attitudes in order to define if the patient is fit to receive a combination of chemotherapy, unfit, and for this reason a BSC, best supportive care, will be the only available treatment approach, or unfit but suitable to receive a less intense upfront treatment. And clearly the fitness of the patient should not be judged based on the disease-related performance status, but rather the patient-derived performance status, so that a high tumor burden determining a high burden of symptoms should not be seen, and a deterioration of the performance status should not be a contraindication to start a treatment for the metastatic disease. Then the second important driver, as previously described, is the treatment intent. Do you want a cytoreduction? Do you need only disease control, meaning control of progressive disease? And finally, the third driver, the molecular markers, and in particular RAS and BRAF mutational status. Then 2 years later, in the update of these guidelines in the Pan-Asian Conference, another driver of choice was included, which was the primary tumor location, based on the evidence of the different molecular landscape of tumors originating from the right side of the colon as compared with the tumors originating from the left side of the colon. And these molecular differences actually translate into a different clinical sensitivity to the use of the class of drugs that are anti-EGFR monoclonal antibodies. So based on these 4 drivers, according to this updated version of the ESMO algorithm for the choice of the first-line treatment, we are able to put our patients in one of these squares and therefore to choose the best upfront therapy in each individual case. How would I suggest to change these guidelines based on the results of clinical trials that have become available in the last years? First of all, I think that a very important news, a seismic effect, has been achieved by the Keynote 177 trial in the first-line treatment of MSI-high metastatic colorectal cancer patients. These patients are around 5% of all metastatic colorectal cancer patients, and pembrolizumab, the anti-PD-1 monoclonal antibody pembrolizumab, was able to significantly improve progression-free survival when compared with the standard treatment with a chemotherapy doublet plus a targeted agent. In this trial, only patients with MSI-high tumors were included, and this trial had 2 co-primary endpoints. One of them was progression-free survival, and a clear improvement in terms of PFS was observed among patients receiving immunotherapy as upfront treatment, with a significant improvement also in terms of objective response rate. The shape of the curve not only shows an improvement in terms of the median values of PFS, but also a clear difference in the tails of the curves, thus suggesting with this plateau that is achieved in the pembrolizumab curve that actually this upfront approach may exert a long-term effect with a long-term benefit for these patients. The beginning of the curve shows a crossover of in the first part of the observation, thus challenging the identification of predictive markers able to identify those tumors that are MSI high but are intrinsically resistant to this treatment approach. Another important result about this trial that was presented at the last ESMO Congress are results in terms of quality of life. In trials in the first line of treatment of metastatic colorectal cancer, quality of life endpoints are often underreported. And in this case, we do not only see a lack of decline, a lack of impairment of quality of life scores that is instead observed with the chemotherapy in the blue lines, and that this is somehow expected also based on the adverse events burden of chemotherapy regimens. But for the first time, in the first line of treatment of metastatic colorectal cancer, we see an improvement in terms of quality of life in the pembrolizumab arm. Therefore, pembrolizumab is able not only not to impair quality of life, but rather to improve the quality of life of treated patients from the very beginning of their treatment history. And another important result was presented at ESMO GI about progression-free survival 2, which is defined as the time from randomization until the second evidence of disease progression. So it includes the first progression-free survival, but is extended until the second evidence of disease progression. And still we see a major impact, a major benefit in the pembrolizumab arm, where in the control arm, around 60% of patients had received an anti-PD-1 or an anti-PD-L1 as part of their second line treatment. So even if the effect of pembrolizumab is now compared with the control arm that has somehow received in the 60% of cases an immunotherapy starting from the second line of treatment, so after the first evidence of disease progression. However, pembrolizumab arm still has a significant advantage and a clinically relevant advantage. So even if this result is not able to answer the question, is pembro best in first line then followed by chemotherapy, or the reverse strategy, because the trial was not prospectively designed to answer this question. However, I think that this is a robust evidence that starting the therapeutic route of MSI high patients with an immunotherapy is a very good, valuable treatment option. So I think that the treatment algorithm will be changed, and microsatellite instability is now the first driver of choice for the first line of therapy, because in the case of MSI high tumors, immunotherapy, and today pembrolizumab as a single agent is approved by the European Medicine Agency, but we know that trials are ongoing combining anti-PD-1 and anti-CTLA-4 antibodies. However, I think that this should be the first treatment option. And all the other considerations about the patient general conditions, treatment intent, RAS and BRAF mutational status, and primary tumor location should be now limited to microsatellite stable tumors that are, however, the vast majority of metastatic colorectal cancers. The second point that I'd like to touch is about the subgroup of patients that are deemed unfit, not optimally candidates to receive a combination of treatment. We have now some new results for this subgroup of patients, and in particular, I am referring to the results of the PANDA study, which was a phase 2 randomized, not comparative trial, where patients with more than 70 years old were randomized to receive a monotherapy or monochemotherapy with 5FU combined with the anti-EGFR panitumumab, or a doublet FOLFOX with light doses of 5FU, again combined with panitumumab. As previously mentioned, this was not a comparative trial, but both arms were compared with the historical results achieved in these patients with the standard treatment, the standard treatment that is usually recommended in these cases, which is the combination of a monochemotherapy, capecitabine or 5-FU, plus the anti-angiogenic bevacizumab. So the results of this trial clearly show a good result in terms of progression-free survival, which was the primary endpoint of the study, with the monotherapy 5-FU in combination with the panitumumab. That allows to achieve similar results to the doublet plus panitumumab with a mild decrease in terms of response rate. Until the results of the PANDA study, we had no specific data in elderly or frail patients with the use of a depotentiated chemotherapy, not the doublet, but the monochemotherapy with the fluoropyrimidine in combination with an anti-EGFR agent. So I think that the fluoropyrimidine and especially 5-FU plus an anti-EGFR are a good option in patients deemed not optimal candidates to receive a combination of chemotherapy, especially if they are well selected by a clinical and a molecular point of view, RAS and BRAF wild type with a left-sided primary tumor. On the horizon, in this setting, which is quite difficult to be objectively described, because it's quite difficult to objectively identify criteria to assess the fitness or not of a patient for a combination of chemotherapy. It is not only, in my opinion, a matter of objective criteria, but also of gut feeling, of medical judgment in front of the patient. However, I think that for this subgroup of patients that actually exist in the daily clinical practice, some news on the horizon may come from the Solstice trial, which is a phase 3 study, including patients that are not candidate for a standard full-dose combination chemotherapy with either irinotecan or oxaliplatin. And this trial was designed based on the results of the early phase 2 TASCO-1 study, randomizing patients to capecitabine plus bev, the long-standing standard of care for these patients, as compared with trifluridine-tipiracil plus bevacizumab, with very interesting results in terms of both progression-free and overall survival. Now, in the Solstice trial, these patients are randomized to receive the same regimens, capecitabine plus bev, trifluridine-tipiracil plus bev, and the trial has completed its accrual, so that we are looking forward to hearing about the results of this study. Another point I'd like to make is about the use of the triplet plus bevacizumab, which is now recommended mainly in BRAF mutant tumors and in the case of cytoreduction as treatment intent in RAS mutant tumors or in RAS and BRAF wild type right-sided. For sure, the triplet cannot be proposed to all of these patients, but careful selection in terms of age, performance status, general condition should be made. Now we have published this individual patient data-based meta-analysis of 5 randomized studies, and when pooling the results of these 5 studies, folfoxirib bevacizumab demonstrates a clear advantage in terms of overall survival when compared with the doublets plus bevacizumab, with a doubled estimated 5 years overall survival that suggests a long-term benefit from this treatment approach. And these results are quite consistent across all the trials included in this meta-analysis. But when we move to the subgroup analysis of these meta-analytical efforts that included more than 1,600 randomized patients, there is no special effect among BRAF mutant patients. The recommendation to use the triplet plus bevacizumab in BRAF mutants was mainly based on the subgroup analysis of the TRIBE study, where amongst 26 BRAF mutant patients, a large magnitude of benefit from the intensification of the upfront chemotherapy backbone was suggested. Now, in this wider analysis, no special benefit is observed among BRAF mutants, and not only we do not demonstrate a significant P4 interaction, but the hazard ratio for overall survival in the BRAF mutant subgroup is more than 1. Another analysis, a sensitivity analysis that was derived by this meta-analysis, is in the subgroup of patients not undergoing R0 resection. So those patients where the secondary resection of metastasis is not pushable, has not been made possible by the chemotherapy, and also in this subgroup of patients, a clear advantage is observed for the use of the triplet when compared with the doublet plus bevacizumab. So how could I translate these results into the clinical guidelines? I think, first of all, that the triplet plus bevacizumab, the role of the triplet plus bevacizumab in BRAF mutant patients is no longer recommendable as the first treatment option. I still do not believe it is wrong, it is a mistake to treat a BRAF mutant with FOLFOXIRI plus bevacizumab, but probably FOLFOX plus Bev is the most evidence-based option according to the recent results. And I think that we should also carefully consider the role of the treatment intent as a driver for the choice of the intensity of the upfront chemotherapy backbone. And I am not only referring to the intensification of the chemo from doublet to triplet in combination with bevacizumab, but also with regard to the use of the anti-EGFR versus bevacizumab in RAS and BRAF wild-type tumors. In fact, at the end of the day, if we consider patients with a RAS BRAF wild-type tumor and the left-sided tumor, doublet plus anti-EGFR are the best upfront option independently of the treatment intent. When we look at RAS mutant tumors, the combination of chemotherapy plus bevacizumab is the best option independently of the treatment intent. And if I agree that intensifying the treatment may be worthwhile in the case when we push a secondary resection or we aim at achieving cytoreduction, on the reverse side of the coin, I do not believe that depotentiating the treatment in the case of disease control as a treatment objective is still a good idea. Moving to treatments after progression, we have 3 anti-angiogenic agents that are available for the treatment after progression: bevacizumab, aflibercept, ramucirumab. We know that we can use all of these agents also after upfront chemotherapy plus bevacizumab. We also have anti-EGFR agents, but the benefit from these drugs is the same also in later lines of therapy. So I think that today we are shifting the use of anti-EGFRs towards the first line when we believe that EGFR is a real driver for that tumor, or we will use in advanced lines if we do not bet so much on the activity of this drug. I think we have now a big news also in this field, which is the role of a molecular marker on top of the therapeutic algorithm, which is BRAF mutational status. Indeed, based on the results of the BEACON study, the European Medicine Agency has approved the use of encorafenib and cetuximab as a standard option for BRAF V600E mutant metastatic colorectal cancer patients starting from the second line of therapy, due to the significant advantage of this targeted strategy when compared with the standard chemotherapy plus cetuximab arm, and no added value of the MEK inhibitor binimetinib on top of the combination of the BRAF and the EGFR inhibition. Finally, moving to the later lines of therapy, again we have in RAS and BRAF wild-type tumors the opportunity to use anti-EGFR antibodies if they have not been previously used, or for all the other molecular subgroups, including RAS and BRAF wild-type, regorafenib, or trifluridine TP-Racil. Today, I think that the fragmentation, the genomic fragmentation of metastatic colorectal cancer is much more heterogeneous, and there are some other relevant molecular subgroups to be identified also in advanced lines. We have already said about BRAF V600E mutant and MSI high tumors. Targeted agents and immunotherapy should be recommended if not previously received. And there are also two targeted agents, entrectinib and larotrectinib, which are nowadays approved for tumors bearing gene rearrangements that are extremely rare, but based on this tissue agnostic indication, EMA has granted the approval of 2 drugs for this very, very small subgroup of metastatic colorectal cancer patients. In the next future, there will be probably other potentially relevant subgroups. For sure, HER2 amplification and the mutations are a target for anti-HER2 strategies, though up to date we only have phase 2 evidence supporting this treatment option. And in tumors still RAS and BRAF wild type in circulating tumor DNA, the opportunity of a rechallenge with anti-EGFR should be probably considered. Also in this case, we have on the horizon potentially a new option, which is the combination of trifluridine and TP-Racil and bevacizumab, as previously described by the Danish trial presented by Professor Pfeiffer. Nowadays, the phase 3 Sunlight trial is currently ongoing in metastatic colorectal cancer patients in the 3rd line of treatment that are randomized to receive a standard option, trifluridine TP-Racil, or the same with the addition of bevacizumab. I thank you so much for your attention, and I'm looking forward to hearing about Professor Pfeiffer and Professor Sobrero comments about my new version of the ESMO clinical guidelines.
Thank you, Chiara, for this very brilliant presentation, as always. It's also original because you were able to go through the different pieces of the recommendation, and you were able to show a series of small adjustments, and also emphasize the 2 major changes. The MSI being put up on top of the beginning of the algorithm, emphasizing the importance of those findings. And I share with you certainly the comment of that representing a seismic shift. I totally agree. Finally, colorectal cancer also has its precision medicine, highly rewarding type of treatment. And the second being, of course, for the BRAF mutated patients. So thanks very much for this very brilliant presentation, and we will certainly address with a couple of questions coming from the audience. I have 3-4 questions here from the audience. Number 1 is a very practical one that I will ask Per because of his experience with the combination of bevacizumab and trifluridine. And question 1 is, may I ask if you have any requirements for platelet levels or other hematological blood values before you give the patient the next dose of Bev when you combine Bev with trifluridine? So do you monitor it or no?
I have not any restrictions on day. They're probably asking about day 15. So I give bevacizumab independent of the neutrophils and platelets.
Completely independent. So you don't check it.
Yeah, I don't check it. Of course, if I see platelets of 10, then I might think a second time.
Sure. Sure. Okay, thanks for this very clear-cut type of answer. There is another question that is very intriguing from the audience, and I love this question, and I put this question to both of you. There is somebody in the audience who is asking, why worrying about shrinkage or no shrinkage? After all, we always need shrinkage when we treat our patients. Now, I don't think this is a sort of heretical type of question. I remember when I went to Japan to explain the new ESMO guidelines, Japanese did not understand why we decided to put the goal of treatment, shrinkage versus disease control. Because again, their comment was exactly the same as the question that is being put now to you, to us. Okay, why worrying about shrinkage? Because you always want shrinkage. You want to comment, Chiara, first and then Per?
Yeah, yes, I should say that I agree totally with this question and with this provocative point. And indeed, also in my presentation, I tried to challenge the role of treatment intent in terms of cytoreduction versus disease control as a driver of the choice of the upfront treatment. I also understand that there are some cases with very low tumor burden with an history of indolent disease, if this history of indolence may be proved, because sometimes we do not know how long it took to the disease to move from a very, very small nodule to the disease that is evident at a certain point. We just have a picture, a snapshot at a certain point, and we do not know how long it took to arrive at that kind of scenario. But in that case, I agree that we can think about reducing the intensity of the treatment, but in the vast majority of cases, colorectal cancer is an aggressive or rather aggressive disease, and I agree that achieving a response is a good effect also with an impact on the subsequent steps of the treatment history. So I fully agree that if it is feasible, I will try to hit hard first and then to depotentiate in a second time.
Professor Pfeiffer, do you agree with this? Because after all, you were there in Zurich in the, and I, go ahead.
I try to teach my patients that it's important that the tumor will not grow. So the CT scan is not for looking for shrinkage. The CT scan is to exclude progression. And of course, if I'm aiming for surgery, then we need shrinkage. And if the patient has symptoms, then the patient needs shrinkage. But if the symptoms disappear, then we do not need a CT scan. So the CT scan is basically for not treating a patient with progression. So I'm trying to explain this to my patients.
Yeah, my personal feeling is that I'm a believer in the fact that we are very good in understanding who are those patients needing aggressive treatment versus those patients who are not in need, according to my clinical judgment, of aggressive therapy. Nevertheless, I may explain all this to the patient, and sometimes whenever I decide that shrinkage is not needed, he may care for having the tumor shrinking. And under those conditions, I change my mind and go for aggressive therapy. Otherwise, the combinations of capecitabine plus Bev, or even better, what you are we are expecting from ASCO, seeing the first line study with trifluridine plus Bev, may be a very good idea in patients with a low tumor burden and with a smoldering type of disease. There is another question, this is for Chiara. Which type of checkpoint inhibitor do you suggest in patient with MSI and at which dose? Well, this probably refers to the issue of combination of checkpoint inhibitors like in Checkmate 142 or the 177 trial with pembrolizumab. What would be your suggestion, Chiara?
I think that today, based on the availability of results from clinical trials, pembro alone is a good option. It is approved by the regulatory agency. I would bet that nivolumab plus ipilimumab that are under investigation in another phase 3 trial will provide very good results also in terms of response, shrinkage, and probably also duration of response. So today I use pembrolizumab. In the future, I'm waiting for the results of the Checkmate H8W trial. I think we will have also the combination available as upfront option, and we will have to decide when to use the combination and when pembro monotherapy or anti-PD-1 monotherapy is enough.
Okay. There is another question regarding the MSI subgroup of patients. And that is, how about the second line after you treat with pembro? Apparently in the US, there is a lot of debate over the use of different type of checkpoint inhibitors from those used in first line. Are you aware of any trial now ongoing in second line with checkpoint inhibitors?
Well, I am sure there are trials ongoing with the continuation of checkpoint inhibitors beyond the evidence of disease progression, but I think that nowadays this practice is based more on anecdotal cases or case series rather than a high level of evidence.
Okay. Dr. Pfeiffer, what is your feeling about the combination of a DNA damaging agent such as the trifluridine, tipiracil? I remember the mechanism of action is totally different from that of fluorouracil. Tipiracil forces trifluridine to go into DNA in the form of FDUMP. Okay, do you think there is a role for combination of that with checkpoint inhibitors? And this is the last question before my conclusion.
That's a good question, Sobrero, and I don't have a chance to answer that. We'll see in the future.
Yeah, I know that there is an ongoing trial, a phase 1 trial of that combination. I just wondered if there was any data out. Okay. So essentially this concludes this meeting. I thank you all for your participation. I thank you, the faculty and my co-chairs, and I thank especially Servier for making this possible. Thank you all for attending, and I'll see you at one of the next segment of this masterclass in GI cancer. Have a nice weekend. Bye-bye.